Hello, today we are going to talk about the use of CT angiography and perfusion in the evaluation and treatment of acute ischemic stroke patients, addressing both standards and potential pitfalls. My name is Edward Sloan. I work with fern.org. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois. I also am Medical Director for New Rose Healthcare Management, helping the emergency department at Roseland Community Hospital in Chicago, a safety net hospital. And I serve as Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This information is being presented at the Clinical Decision Making in Emergency Medicine meeting, June of this year. I want to give my thanks to Joan Esbrey-Cullen, Andy Godwin, Andy Jagoda, Ginia Ports, and Scott Silvers, with whom I've worked at this good meeting for several years. I have no financial conflicts. I serve as the Fern President and Board Chair. Let's talk a minute about the core infarct and the ischemic penumbra. What's the difference between the core infarct and the ischemic penumbra? We know that both areas have poor flow through some target vessel when an acute ischemic stroke occurs. The core infarct has bad cerebral blood flow and a bad cerebral blood volume. This means that with poor flow and poor volume of blood, there is limited oxygen delivery via hemoglobin. There is non-salvageable tissue, and the changes in this area over time become irreversible, and this core infarct is permanent. The ischemic penumbra, which is different, has cerebral blood flow and cerebral blood volume, which is almost adequate for maintaining tissue integrity and avoiding infarction. In fact, there's just enough cerebral blood flow and cerebral blood volume that with optimal care, early restoration of blood flow through the target lesion, tissue viability can be maintained and the ischemic penumbra will not then become dead core infarct. And so the main question is, how is it that we can restore tissue oxygenation to this ischemic penumbra so that with good care, the ischemic penumbra becomes viable again and long-term effects are minimized, versus a situation where we are unable to restore adequate blood flow and this ischemic penumbra becomes more infarct tissue, which will impact both morbidity and mortality long-term. So how is the size of these two tissue states, core infarct and ischemic penumbra, how are they related? You can see here in this graphical representation, the core infarct is in black. On the left, a small infarct and a large ischemic penumbra at 30 minutes. And you see at 2 hours, the core grows. And at 12 hours, all of that ischemic penumbra tissue has now become established infarct, and long-term effects will be manifested because of the large volume of the core infarct. If, on the other hand, it is possible to avoid changing that ischemic penumbra into core infarct, and if it is possible to minimize the size of the core infarct, the long-term complications are minimized and the patient has a better outcome when looking at modified Rankin scale at 90 days. It's now important to consider large vessel occlusion, or LVO, when considering CT multi-modal testing in acute ischemic stroke patients. Why is the presence of a large vessel occlusion important to detect in acute ischemic stroke patients? Large vessel occlusions, LVOs, cause approximately 1/3 of acute ischemic strokes. Yet, these LVOs are responsible for 90% of the mortality related to this condition and the severe neurological disability in acute ischemic stroke survivors. In other words, the LVOs are the lesions that are most important for causing morbidity and mortality in patients who present to the emergency department with acute ischemic stroke. And we know that endovascular thrombectomy and other therapies decrease disability, improve functional outcomes, and decrease mortality over standard therapies, especially in patients with anterior circulation large vessel occlusion. And so why is it important to detect these LVOs? Large vessel occlusions often will cause a large volume of at-risk ischemic penumbra, which requires acute therapy. There's a greater likelihood for a rapid infarct to grow or to grow rapidly in this at-risk tissue, especially with the presence of an LVO. We know that there's a limited therapeutic window for endovascular therapy with LVOs because the decreased blood flow and oxygenation is so severe with LVOs that there is a limited amount of time for preventing the ischemic penumbra from becoming a core or growing core infarct. And with patients with LVOs, we need to consider transfer to a comprehensive stroke center with these patients because in centers that do not have the ability to go to the IR suite and provide endovascular therapies, it is necessary to rapidly get these patients transferred and to coordinate the planned EVT therapies, especially for patients with large vessel occlusions. So in summary, LVOs cause the enhanced patient risk and the need for optimized treatment decision making, which could include transfer of patients to a comprehensive stroke center. Now, what is meant by the VAN assessment for possible large vessel occlusion? This article demonstrates that it is possible to estimate whether there is a large vessel occlusion without specific CT multi-modal testing. When we talk about VAN, we're talking about vision, aphasia, and neglect. And these are functional neurovascular anatomy deficits. These are cortical abnormalities that suggest a large vessel occlusion. And in fact, they are likely to provide some clinical utility as compared to simply saying large strokes are more likely large vessel occlusions, and by large strokes we mean NIH stroke scales greater than 5. So let's talk about this a little bit more. How do we compare the VAN assessment versus the NIH stroke scale greater than 5 for detecting a large vessel occlusion? Both of these tests are 100% sensitive with 100% negative predictive value. That is to say, if you do a VAN assessment and there's no visual, aphasia, or neglect abnormality, or the NIH stroke scale is 5 or less, it is highly likely that there is no large vessel occlusion, and in fact, it's more likely a lacunar infarct. We do know from this study that the VAN assessment is more specific, 90 versus 74% versus NIH stroke scale greater than 5. And the VAN in this sample size, or this group that had a 23% LVO rate from this study, that the positive predictive value is higher with the VAN assessment versus simply an NIH stroke scale greater than 5, 74 versus 58%. In other words, VAN assessment had fewer LVO false positives versus this NIH stroke scale greater than 5 cutoff. And it does suggest that if you simply do a neuroanatomical clinical exam, that VAN can detect the presence of an LVO without over-predicting the likely presence of an LVO. So, in summary, what does this VAN assessment mean? In patients in whom you detect extremity weakness, you then look for these 3 VAN cortical findings. If one of them is present, it suggests that there is a likely large vessel occlusion. So the VAN assessment, which can be done without any neuroimaging, facilitates LVO detection. It allows for the treatment of LVO by rapid thrombolysis and the transfer for EVT. If the VAN is negative, then LVO is much less likely, so that other neurological etiologies for the symptoms may be detected not with CT multimodal studies, but with MR testing. In other words, if the VAN assessment is negative, perhaps there's a less urgent need for CTA or CTP if it's not immediately available. And if the VAN is positive, there's a good chance that an LVO is present in a clinically relevant population of patients who are at risk, and we know that this was a 75% positive predictive value in this small study that had a 25% LVO rate. Thank you for your time in learning more about optimizing the care of patients who present to the emergency department with acute ischemic stroke. You can scan this QR code to find out more about our social media links, and you can send me a question to fern.org@gmail.com or edsloanmd@gmail.com. Once again, thank you for your participation in this Fern educational effort. Have a good day.